in the last 6 to 12 months, there's been quite robust literature coming into more of the outpatient population of pursuit of earlier rhythm control is having better outcomes, East AFNet-4 trial being the highlight of those. But you're asking particularly about these, patients in the setting of acute illness, with atrial fibrillation and if and how to pursue rhythm control. So I think about that, um, again, it's just like we had a certain number of questions of when to think about anticoagulation. So I have a certain number of questions I ask myself or I'm asked the patient or the primary team is one, is the patient symptomatic? Does the patient not feel well in the rhythm? Um, Two, can the patient be anticoagulated? Because if we're going to, just like I mentioned before, if we're going to pursue either chemical or electrical cardioversion, we need anticoagulation in the pericardioversion period, and we need anticoagulation for at least 4 weeks, 4 weeks after that. Um, Number three is the atrial fibrillation persistent? And this is goes to the electrical cardioversion question. I always, push the house staff that I'm with to check the telemetry because if a patient was in AFib last night when you left at 5, 6 p.m. and they're in atrial fibrillation when you get there at 7:30 in the morning, but they were in sinus rhythm for 3 hours in the middle of the night, pursuing an electrical cardioversion is somewhat futile because this patient has already demonstrated themselves as someone who's going in and out of atrial fibrillation. It may be someone we could consider antiarrhythmic therapy for to suppress the atrial fibrillation, but if someone's going in and out of atrial fibrillation, it's not someone we would pursue an electrical cardioversion for. And so, like I mentioned, symptoms, can they be anticoagulated? Is it persistent? And then the fourth thing, which I think is the hardest one to answer, is do we think that this acute stressor is on the mend or headed in the right direction? I mean, if the patient is still floridly in sepsis or uncontrolled or spiking fevers or hyperthyroid or actively bleeding, the atrial fibrillation is a response to what is going on in this I to the patient, what's acutely going on. And so shocking the atrial fibrillation, one will be futile, and then two is, dangerous. You're giving, sedation, and often sometimes propofol to sedate a patient that drops a patient's blood pressure, and sort of to what end when the stressor is still going on, the likelihood of recurrence of the atrial fibrillation is high, and you may end up just dealing with complications rather than any benefit.